Morning. This is 24th of February 2026, and here we are with the Hindu. So the first news is that the center unveils a policy to tackle terrorism threats. So Prahar states that India faces terrorist threats on all three fronts: water, land, and air. The policy adds that capacities have been developed to protect critical sectors of the economy. Okay, so recently this policy has come, that is the Prahar. Okay, so India has released its first ever national counter-terrorism policy and strategy, Prahar. The nine-page document details the threat profile, counter-terrorism strategy, and the way forward. It lists key agencies and responsible for a specific task. And it stresses that terrorism is not linked to any specific religion, ethnicity, nationality, or civilization. So that is a good thing. I think not much important. So let us move to the editorial piece. So yes, here we have adolescent mental health. Okay, so good article about the mental health. So mental health problem is becoming prominent in India right now because of the excessive use of the internet. Okay, also there are many things, so let us try to understand. So the quite crisis of adolescent mental health in India. So let us try to understand. So here is the thing: the passing of three adolescent girls in Ghaziabad, Uttar Pradesh, earlier this month is a case that deeply unsettled the public. The intense media attention reflects collective grief, but treating this strategy as an isolated incident risk ignoring a larger reality. India faces a growing, largely neglected crisis in child and adolescent mental health, rooted in early vulnerability and worsened by an unregulated digital environment. Uh, Mental health challenges are no longer limited to adults or older teens. Clinicians increasingly see anxiety, depression, attention disorders, and behavioral issues in much younger children. Yet, many families, schools, and even parts of the healthcare system still view these as adult issues. In fact, emotional and behavioral disorders can appear as early as 4 to 5 years of age. Early trauma, neglect, and chronic stress can disturb emotional cognitive development, often resurfacing with greater intensity during adolescence. These conditions have also grown more complex, where children without a single diagnosis, comorbidities are now common: attention deficit hyperactive active disorder with anxiety, depression with compulsive digital use, learning difficulties with emotion distress, making early recognition crucial. The extent of the problem. Population level data mirrors that the clinicians observe daily. Findings from the National Mental Health Survey and subsequent studies suggest that between 7% to 10% of Indian adolescents have diagnosable mental health conditions. 5% to 7% of school-age children have ADHD. Yet early signs, withdrawal, impulsivity, certain behavioral changes are often dismissed, leading to academic, social, and long-term emotional harm. India faces an acute shortage of trained child and adolescent mental professionals, with fewer than 10,000 psychiatrists for a population exceeding 1.4 billion, and only a small fraction specializing in child mental health. The gap is stark. Shortages of clinical psychologists, child psychologists, and psychiatric social workers further strain an already fragile system. Families are left to navigate fragmented care largely on their own. Childhood vulnerability has been amplified by a transformed digital landscape. The rise in mental health concerns parallels the spread of smartphones and low-priced internet data, now used by over 800 million Indians. Many of them are children COVID-19 pandemic further embedded screens into daily life, including education, recreation, and social interaction. With school work, communication, and entertainment all on the same device, boundaries have blurred. Internet addiction, which is marked by loss of control, irritability, sleep disruption, and social withdrawal, is now a routine clinical concern. As early as 2019, World Health Organization issued guidelines and had cautioned against excessive screen exposure among children and adolescents, highlighting its adverse effects on sleep, attention, emotional regulation, and overall well-being. These recommendations predated the pandemic. It is important to understand that the excessive screen use does not cause neurodevelopment conditions such as ADHD or autistic spectrum disorder. However, it can significantly exacerbate symptoms, delay diagnosis, displace the human interaction essential for healthy brain development during periods of heightened neuroplasticity. In vulnerable children, this displacement can have lasting consequences. Against the backdrop, parents and families have to assume a central role. They are not merely caregivers, but a child's first mental health buffer, as the least observers of emotional change and the most consistent source of psychological safety. Trauma-informed parenting, which recognizes how stress, loss, and adversity shape behavior, must extend beyond clinical settings into everyday life. Listening without judgment, noticing changes in sleep, mood, or social no, listening without judgment. Okay, without judgment, noticing changes in sleep, mood, or social engagement, or seeking help early can dramatically alter outcomes. Support groups are proven to further strengthen this protective environment. Parent support groups reduce isolation, normalize help seeking, and enable safe learning. Adolescent peer support group provides safe spaces for emotional expression, resilience building, and development of coping skills. Evidence consistently shows that such collective community-based approaches are more effective than isolated clinic-centered interventions. Schools are a weak link. Schools, however, remain a critical weak link. Academic performance continues to dominate institutional priorities, often at the expense of emotional well-being. Examinations, rankings, and competition define school future, while structured attention to emotional regulation, stress management, and happiness remains limited. This imbalance is neither benign nor sustainable. Mental well-being is foundational to learning, creativity, and long-term productivity. Without it, academic success is fragile and transient. A further challenge lies in the gap between evidence and practice. India's research based on child and adolescent mental health, digital behavior, and early intervention has grown steadily. Yet, transition into routine care remains slow. Pediatricians often the first point of contact for families must routinely inquire about emotional well-being, sleep patterns, skin use, and peer relationship, not just physical growth. Teachers, counselors, psychologists, and all professionals working with children need a structured training to identify early signs of mental health problems and internet related harms. Stigma continues to delay care with families often seeking help only during crisis. uh, Only during crisis. In today's context, child and adolescent mental health in today's context, child and adolescent mental health is intricately linked to social media and internet use. These concerns were explicitly acknowledged in India's Economic Survey 2025-26 released in June 2026, which highlighted rising mental health challenges among youth people and proposed a range of preventive strategies. Several Indian states are drawing on precedents in Australia, France, and South Korea are considering regulating steps to limit adolescent social media use. This is an idea whose time has come, provided it is implemented thoughtfully alongside education and support rather than punitive controls. Now, actions to implement policy and pragmatic action must now align with reality. India can strengthen existing India can strengthen existing platform, the national mental health program, school national services under Ayushman Bharat Health and Wellness Center initiative, the tele mental health initiative by introducing routine school based screening, training teachers and frontline workers in early identification of child and adolescent mental health issues, and reinforcing referral pathways. Earmarked funding for child mental health initiatives, clear guidance on digital use in schools, affordable community-based counseling, especially for low and middle class families, are urgently needed. Implementation, however, faces practical hurdles. Stigma surrounding mental health remains pervasive. Psychiatry carries an even heavier burden of the fear and misunderstanding. Concerns about labeling, judgment, and long-term consequences often delay help seeking until distress escalates into crisis. Normalizing conversations around mental health within families, schools, and healthcare system is not optional, it is a public health imperative. The Ghaziabad case must not remain just a headline. Preventing similar tragedies coordinated. Just a minute, where we were. Similar strategy requires coordinated action between schools, PTAC, pediatrician, mental health professor, and communities. Even modest, timely interventions can change developmental paths. While psychiatry and digital platforms have expanded reach, access remains unequal. Extending these services to undeserved families alongside investment in training and interdisciplinary care must be priority. Parents need guidance on early warning signs and healthy digital use. Schools should make mental well-being part of daily learning. Pediatricians must screen for emotional and behavioral issues, and community support network strengthen. Policy must treat mental health as essential to child development. Equally important is a need to shift in what we value as outcomes. Childhood should foster well-being, resilience, and connection, not just competitiveness. Neglecting it now will carry for higher social and economic cost. I hope this much is clear. It is about the mental health, which is increasing now among the adolescent. Okay, because of so many reasons. They have also highlighted the cause of the mental health. Then what needs to be done. Okay, so all these things you will get here if you read. Thank you so much.